summary of what he thinks about your transplant. Thank you, sir, for the introduction. Thank you, organizer, for inviting me. Since there's a short of time, I'm just uh, coming to the topic. Just discuss the overview, not going in much detail of it, but what is liver, uh, living donor liver transplant? Who can be the donor? And what are the success rate, complications, and how it different from the this though majorly is no different with a deceased donor, but there are some differences. So as we know already, CLD is irreversible, and once it becomes decompensated, the lifespan gets shorted. The median survival is almost 2 years, and it's been seen every year. Every year, around 1 million cases being registered as CLD. Of them, is 30% is the decompensated. So almost 3 lakhs individual diagnosed as a decompensated liver disease. And in 2015, you can see 3 lakhs people died because of the liver disease. And if you compare the globally, worldwide, India is the fifth among the fifth contribution of the death. India is the 20% is from the India. So liver transplant is the effective, but there's significant risk. If you look at the in India, if we see how many they need a liver transplant, of course, 25 to 30,000 liver transplant needed in India. But at the opposite end, we are doing 1,500 to 1,600 liver transplant totally, maybe because of lack of awareness, financial, or the donor availability. And of them, if we see the deceased donor, that when the patient is dying, we can take the liver and kidney and transplant it to the suitable recipient, and we can give them in life. So the deceased donor liver transplant is only 5%. 5%. Why? Because in the south it is majorly been deceased, not majorly, but 30% is the deceased donor, and in the north or in the east part or in the central and the Delhi part is almost 1 to 3%. So here I just wanted to say we say कि कन्यादान बहुत सबसे बड़ा दान होता है, लेकिन आई वुड से कि जो ऑर्गन डोनेशन करता है वो उससे भी वो दान वो सब उससे भी बड़ा होता है, वो दूसरे को एक नई लाइफ दे रहा है. So the Henry Bismuth said he is the first. He did the first deceased donor. The worst complication of liver transplant is to die before receiving a transplant. So this is the historical day for not only for India, not only for Apollo, it's for India. This is the 15th November 1998. The first successful pediatric liver transplant performed in India. And he became the doctor. He's the MBBS. He just completed the MBBS. I'll show the coming slides. So we started from 1995, but initially there was some watershed area, a little less. As the awareness goes up, we have reached, we were doing the more than 300 transplant. Now we have done, till date, we have done the more than 4,000 transplant in Apollo Hospital. So here, why the alcohol is the major cause? Because we are receiving the patients from the Pakistan, we are receiving from the Bangladesh, where the alcohol is less. But if, of course, we compared from the India, the alcohol was the commonest cause for the decompensated liver disease, and hepatitis B is the commonest cause for the hepatocellular carcinoma. And for the etiology in the pediatrics, of course, is a genetic extrahepatic biliary atresia is the most common cause. And if you look this certain advancement, we were not using the HPIC, patient being managed with the nucleoside or nucleotides oral drugs, and there's a concept of conferring passive or adaptive immunity developed in patients, those who receive the those who are having or those who receive the total core antibody positive donors. And in patients of CV, child A, child B, of course, we don't transplant. You give the sofosbuvir, ledipasvir, teclatasvir, or the velpatasvir. And child C patients, after the transplant, we give 3 months of uh, 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 oral oral drugs depending upon the genotype. If the pan-genotypic, we can give the sofosbuvir plus velpatasvir. So, should all the patients receive the transplant? Of course, no, because we would like to see the success rate. Like a patient is a multi-organ failure, we would not like to do the transplant in that part. Disease progression, of course, previously the high DNA level or the cRNA level we don't do because there's a post-transplant, there's a recurrence. But with the advent of newer drugs, this B or C, we can do the transplant even patients having a high RNA or DNA level. Disease recurrence and if a patient is before advanced SCC, definitely with the portal vein thrombosis, we don't do the transplant because there's chances of there's a recurrence of SCC. Donor availability is the most important as far as the India is concerned, because in India, majorly is the living donor liver transplant as compared to the West, where the deceased donor transplant is the most common. The compliance is the post-operative restrictions, especially for the alcohol, and cost, of course, in India is the major factor. So, two main purpose of liver transplant in the liver disease is prolonged survival and improve the quality of life. We select those CLD patients where the survival is less than 1 year. This is depending upon the child and MELD score. I'm not going to detail of that child MELD or MELD sodium score. The child score, if there's a child A, the survival is high, and once it's child C, the survival is less. So in patients of late B or child C patient, we advise for a liver transplant, where the survival after transplant is more than 90% in 1 year and more than 80% for 5 years. If we compare for the MELD score, you look at this is the survival with them when there is a less than 15, and the survival is almost equal. Once it's more than 15, with the transplant, survival after transplant gone up. So MELD more than 15 is you refer the patients for a liver transplant. So this is again patients with decompensated cirrhosis, where their patient is developing ascites, patient developing varices, bleeding. They are decompensated and the survival is less. So we refer those patients for liver transplant. So these are the complications: bleeding, uncontrolled ascites, spontaneous bacterial peritonitis, and hepatic encapsulation and hepatorenal syndrome. They definitely need referral for the liver transplant. And the probability of death is increased once these complications were having the patients of CLD were having these complications. The post-transplant survival, 1 year survival is more than 90% in most of the centers. So transplant if child is more than 8, the late B, more than 14, MELD. First major decompensation, as I showed the complication, type 1 HRS, fulminant hepatic failure, that is the ALF, and SCC within UCSF criteria, the hepatocellular. Many center follows different. Certain follows Milan, certain follows UCSF. There are many criteria for UCSF, and few centers they follow any amount of hepatocellular carcinoma in the liver, but there should not be extra hepatic spread. Even they were doing the liver transplant, especially in India. They say it's because of relatives bonds. It's not in the West. They follow certain criteria, but in India, because it's a LDLD, it gives a certain life to the patient as compared if we don't do the transplant. And in rare conditions, we do in patients of the PBC and the Budd-Chiari to improve the sometimes for the itching and sometimes for the quality of lives. So there are certain contraindication. I just focused on absolute contraindication where the pulmonary hypertension is more than 50. There's substance use, that patient either taking some or other from either alcohol abuse or certain other abuse drugs. Patient is having not HIV, but AIDS defining illness and the extrahepatic malignancy. These are the absolute contraindication for a liver transplant. So before onset of life-threatening complication, because if the MELD score is going up, the post-transplant survival, if you we do the transplant here, when the MELD score is 15 and MELD score 14, the mortality goes up by two to three times. So pre-operative, once we patient admitted, we do the pre-operative evaluations. We optimize the patients by giving fluid balance, cutting down on diuretics, improve the nutrition, improve the lung function, and treating infection before doing transplant, and decrease that will decrease the post-operative hospital stay. And definitely, every liver transplant patient needs a psychological, social, multidisciplinary approach with surgeons, hepatologists, anesthetists, coordinator, psychiatrist. So this is a Milan criteria. We follow the UCSF criteria for a hepatocellular carcinoma. And when there is a outside UCSF, but without portal vein involvement, we do the PET-CT. If there is no metastasis, we downstage the tumor with a TACE plus minus SBRT or tear and reassess the alpha. We at our center, we take alpha fetoprotein less than 100 before doing a liver transplant, and we assess the triple phase CT after 8 weeks after the TACE. And if there is a vessel involvement, definitely we do the TACE plus SBRT or the tear. VSS at 12 weeks. Of course, we look at either the portal vein tumor is become not hyper intense or not the CT triple phase. It should not be hyperdense, or it should not be. I mean, that tumor should be dead before taking for a liver transplant. And we look at the alpha fetoprotein and PET-CT. We just do that. There should not be any extrahepatic spread. So for acute liver failure, we follows the King's College or the dynamic criteria depending upon the INR, bilirubin, ammonia, or the hepatic and CAF level. But most of the centers, they follows the King's College criteria. So before we do this CT scan, we selecting because sometimes ACL are presenting as ALF, and there is select the donor because the cooling off period is not possible. We can't. We are trying everything that the patient will get better. I will come to that. But till then, we just ask the relatives be ready for a liver transplant. We come up with a suitable donor. We monitor the progress without FFP, intervene if deterioration in 72 hours or grade or progression of the hepatic and CAF. So, with grade 4 in CAF, CRRT, we start the CRRT as the ammonia level is more than 100. We target the ammonia level less than 100. This allows for more time required for preparation of a transplant, and CRRT is to continue the day after the transplant. Ammonia level decreases in the first 12 hours of CRRT. Transplant can usually be delayed, and CRRT required for 3 to 5 days. And we, in our center, we out of 100, if suppose of 100 patients they came, we haven't done the transplant for 60%. We salvage the patient without liver transplant in patients, those who came with the acute liver failure, with the help of medical treatment and the CRRT. So this is the most common slide where most of the referral which we get, who can be the donor? They have a money, they have this patient, but who can be a donor? The age should be 18 to 50 years, relative, and it is related to the recipient. There should not be comorbidity, long-standing diabetes, or the hypertension. Should not be taking actively smoking, OCPs, or abstinence for 6 weeks prior to surgery. It's not a absolute but relative. BMI should less than 24/7, less than 27 for Indians, 30 for Middle East patient. Acceptable remnant, whatever we take, almost 65% to 69% of the liver from the donor. We at least we try to leave 30% of the liver into the donor, and LAI should be more than 5. That is, this represents the fatty liver. We accept the fatty liver up to 15%. So size of the graft, quality of graft, and the type of graft and anatomy graft is all important in patients those who are for the recipient and for the prolonged survival. The right lobe, left lobe, right posterior graft, or the dual lobe, two donor for one patient. We are doing all four type, and we have compared it all the left lobe, right lobe, dual lobe, or the right posterior sector, and it all depends on the all the doctor. I just forgot the name of the surgeon, but he tells you better things when we take the right left. It is based on basically the hepatic veins, portal vein, and the artery, which where they make a which how much part we should take, and it should be depending upon the GRWR. I'm not going detail on that. So this is the hepatic vein anatomy, and we cut the liver, we make the incision according to on this hepatic vein distributions. So donor safety is the top priority. Adequate volume should be left in patients of donor, and we should not take a excess fatty liver, because if you leave it, if you take it, then the recovery in patients of recipient is, I mean, maybe prolonged recovery, or maybe sometimes it behaves as a small for graft. So we have a 9 ICU bed, HDU beds, and the floor beds. We sit together 1 week prior to for a transplant, multi-step counseling, and detailed presentation to the ethical committee. This we compared as compared to the West. The cost in Apollo for liver transplant is 20 lakhs, including both donor and the recipient surgery. So most of the right lobe liver we used to take without MHV. Bile leak stricture we see at around 6 to 7% of the patients. Wound pain, psychological trauma in case of, definitely if the patient die, we do not disclose at least for 7 days to the donor. So we did ALF till now 25 ALF we do the transplant, and the one is of them is the ABO incompatible, and 24 is the ABO compatible, and one is most of they were the children, they were the less than 10 years of age, and the output the success rate is around 82%. So this is ABO incompatible. Till now, we have done the 37 ABO incompatible liver transplant, and this is a pediatric 5%, adult is 8%, and the ABO incompatible liver transplant we achieve 88% survival, 1 month survival. So ACLF, if we do not do the transplant, the mortality is very high in comparison to when we do the transplant. So we compared in our unit. So waiting for conservatively managed, try to improve them, and then do the transplant. The mortality we saw that is 57% as compared to 18%, unless there should not be active. We should not do the transplant in active infection or the progressive renal failure. We compare the type 1 ACLF type 1, type 2, type 3 according to the class ACLF classification, and we found after 1 year there is no difference. So this is a CKLT. We did till now 19 transplant, 17 were alive and 2 were died, and most of the patients with the diabetic nephropathy. LDLT versus DDLT, till now we have done 566 transplant. Of them you can see only 20 transplant was the decrease, and 566 was the live donor. So you can only 3% of them we just able to do the decreased donor. So it's a definitely we need to be more aware. We need to more counsel the relatives, especially those who are who's a neurosurgeon or the neurologist. They will counsel better than, because we selected the brain donor for liver transplant, decreased donor liver transplant. So there are certain we saw in out of 94. This is this is the old data. 94 we see the ALD again they started drinking. the SCV progression with when we were not having the oral drugs. Again they develop a cirrhosis and grade 2 fibrosis. And SCC recurrence, we also see even with we follow the UCSF criteria, the 10% around there's a recurrence, and we follow the transplant within UCSF criteria. Rest, we downsize before the liver transplant. So complications we know because we use these either the cyclosporin or the tacrolimus, nephrotoxicity, neurotoxicity, cardiovascular complication we see rarely. Risk of infection, of course, we see most common is the CME infections. Risk of malignancy, we see in pediatric population 2 EBV virus causes the lymphoma, but in adults only we could see only we did majority of 70% of adult, we see only one lymphoma in patients because of the immunosuppressions. So just indications is the same for LDLT, DDLT. If you compare, definitely there's a study which compared the LDLT and DDLT. The DDLT, both are equal, but I would say if we choose it rightly, DDLT because you took whole of the liver and the artery is big, vein is big, and the bile duct is weak, so less complication as compared to LDLT. High MELD child score should be MELD score more than 15 or child late B that is 8. ALF, we follow the dynamic criteria, James criteria. Experience has so many things. Because of the learning curve, initially our mortality when we started way back in 1997, it was success rate was 60%, 50%. Now 2007 to the success rate rise to 15%. Now the 7 or 8% we give them mortality if we choose rightly patients. Those who are not in ICU, those who are not in organ failures. So in those 95%, 94% is the success rate. Thank you for that patient listening. I just wanted to 2-3 patients. These are the Philippines patient. You can see this is how malnourished is only 4.5 kg, and this is after a year. This is again. This is again. This is a baby. This is after a year. This is a Pakistani girl who came. We transplanted at the age of 12 years. This is her marriage picture. She sent to us, and this she was 21-year-old, and this patient came to us with this condition, and this is before we just nutritionally we put ART, we maintain the nutrition, and this is after 1 month of transplant. This once she came in the OPD after 4 months of post liver transplant. So this is our team. This is Dr. Nirav, who is the transplant surgeon. This is mine. And I just wanted to say one more thing. Not only my unit, we are 4. Gastroenterology, we look up, myself look up the liver and few endoscopic procedure. We are doing some few difficult rare procedure also. Dr. Irtaja, Dr. Mohammed Irja is one of my colleague. He will just show you the just in 5 minutes. He'll show you the some rare procedures which doing in our unit.